Thank you. Okay.
I think I just made myself nothing.
I just made you co-host. I did.
Okay. Thank you. So I've given the ones that had jumped on before you got on, I've given them permission. So anybody who's just joined, we'd have let me see. It looks like everybody right now has permission. So anyone else that joins from here.
Okay, thanks.
Thank you. Kelly, I have 32 registered too, so we may need to wait a little bit, but I don't see our experts on yet either.
Recording in progress. All right, I see both of our experts, Dr. Rosnovely and Dr. Badley. Thank you for joining us. Dr. Rosnovely, can we check your sound real quick? Just say hello.
Can you hear me okay?
Yep, good.
Perfect.
Dr. Badley, are we, can you turn on your...
Hello.
Say that again, Dr. Badley. Oh, there you are.
Yep, I'm here. Can everyone hear me?
Yep, I think we're good. All right, thank you. And it looks like we are getting close to having everybody we're expecting. So I'm just going to hit record here. And why don't we go ahead and get started? First of all, Dr. Badley, Dr. Rosnovely, thank you for making time today. And journalists, thank you for attending. If you could both please introduce yourselves, give your name, title, and spell your name. And then we'd love to hear your thoughts, your opening thoughts on the state of therapeutics, including the new news from the FDA on kids and monoclonals, and then the antiviral pills too. So Dr. Badley, do you want to start?
Sure. So thanks everyone for being here. My name is Andrew Badley, B-A-D-L-E-Y. I have several roles at Mayo. I'm a professor of infectious disease. I'm professor and chair of the Department of Molecular Medicine, and I'm chair of the COVID task force at Mayo Clinic. I think right now is a busy time in the state of COVID, certainly in the state of COVID and in the state of Minnesota. We have a lot of cases. I don't think it's going to be going away anytime soon. Our therapeutic preparedness, I think, is improving. I'll leave comments on the monoclonals to Dr. Razanable. That's his area of specialty and interest and expertise. Regarding the hopefully soon approvals of oral antivirals, I think it's a great opportunity. Both drugs have been studied well in terms of understanding how they behave for patients with COVID disease that is high risk of progressing. There appears to be some differences between the therapeutics, with molnupiravir having some safety concerns, particularly in pregnancy, and it appears to have a efficacy in the 30-ish% range. We've not yet had the opportunity to see their data in a peer-reviewed state, but that is the report from the company. Paxlovid, I think, is another great opportunity. It is, in my opinion, a very remarkable drug in that it took advantage of the past several decades of enhanced understanding in molecular simulation and crystallization, which allows us to understand protein structure. And this drug has been developed based upon understanding that structure and learning ways to combat it with that. So this is truly computer-aided structure function design oral antiviral. It targets the protease in SARS-CoV-2, and its early safety and efficacy data appear excellent. By the report made by the manufacturer, it has an almost 90%, in fact 89%, ability to prevent hospitalization and death in those at high risk. We're also, I'm sure, going to have a lot of questions about the Omicron variant. I think it is correct to say that we'll see lots and lots more cases of the Omicron variant diagnosed, including in the United States. We don't yet know what impact this will have on the pandemic. There are some reports that the disease penetration is lower with the Omicron variant, meaning that people get less sick from it. If that's true, that's a very good thing. It certainly appears to have a high replicative capacity, meaning that it infects people very, very readily. So I think now is a very critical time in our management of the pandemic and our response to it. And so I expect a robust conversation today. Ray?
Yep. Thanks, Andrew. I'm Dr. Raymond Razonable, R-A-Z-O-N-A-B-L-E. I am professor of medicine at the Mayo Clinic in Rochester, Minnesota, and serves as the vice chair for the Division of Infectious Diseases. Been leading the monoclonal antibody program here since the clinical trials, as well as when it was available for emergency use authorization in November of 2020. There are currently 3 authorized products that we use. We have the combination of bamlanivimab etesevimab from Eli Lilly. We have the combination of casirivimab imdevimab from Regeneron, and we have the Glaxo product called sotrovimab. We are still in the era of Delta, even if Omicron has been in the news lately. The predominant variant circulating in our communities remains predominantly Delta, and all the monoclonal antibodies that we have available are effective for the Delta variant. Our program has infused almost 20,000 infusions of monoclonal antibodies since we started in November of 2020, and we have seen seen remarkable outcomes in terms of it, reducing the risk of hospitalization and progression to severe disease, reducing mortality, as well as reducing the need for intensive care unit. Dr. Badley had mentioned about the Omicron variant that is now in the news lately. We still do not know how Omicron will be impacted in terms of the monoclonal antibody products that we do have, but we will learn more of this as new data comes in.
All right, thank you both. So one of the first questions we have here from Catherine Richard, what do we know about how well available COVID treatments work against Omicron? Not just monoclonals and antivirals, but the existing treatments.
So maybe I'll take the first crack at that, and Ray, I'm sure you'll have something to add. So if you look at the structure of Omicron and compare it to the structure of previous strains, including Delta, the site where there is the most change is in the spike protein. So for any therapy that works against the virus through a mechanism that does not involve the spike protein, it is anticipated that Omicron will be equally favorably treated with the existing therapies. And so I'm talking specifically there about the antivirals, remdesivir, and the 2 new oral antivirals that hopefully will be approved in the relative near term. In terms of other modes of therapy for COVID disease at a hospitalized stage, so steroids and some of the other immunomodulatory agents, there's absolutely no reason to suspect that they will behave differently with Omicron variant infections should they require that level of care compared to Delta or any of the others. The place that it remains unknown is for those therapies that target the spike protein. And those therapies are the monoclonal antibodies, possibly convalescent plasma. And the reason I say possibly is that some of the governing bodies which advise on therapeutic use have recently changed their recommendations to not use convalescent plasma outside of the use of a clinical trial. And then, of course, vaccination. We really have more questions than answers in this space, but one of the principles I'd like to say is that protection is not an all or none event. So it's not yes or no, there's degrees. And so I think with the accumulating number of mutations which are on Omicron, I think it is probable that some of the vaccine-induced protection or some of the monoclonal antibodies may have slightly reduced activity against the Omicron variant, but I don't think it's correct to say that it'll have no protection. And so really it needs to be thought of in a linear range, that the protection might go from, and I'm making this up totally, might go from 90% to 70%. And I think it's important to put that in perspective. If at the beginning of the pandemic, somebody would say, I have developed an antibody that is 70% protective against hospitalization and or death, that's a remarkable outcome. That's truly a remarkable outcome. So I think this is very much a glass half full likely scenario that there's likely to be ongoing activity of all of our therapies against the Omicron variant.
What would you add to that, Dr. Rosanavle?
Yep, just to kind of emphasize what Dr. Badley had said, just because the Omicron has the described mutations mainly on the spike protein, it is concerning that some of the monoclonal antibodies may have reduced efficacy against this variant. But having said that, just like what Dr. Badley had mentioned, it's not an all or none. There may be some reduction, but probably may still be beneficial. I also would like to kind of point out that vaccination probably is going to be one of the main protection from this, because with vaccination, we only not induce antibody development, but we also will have T-cell responses that will be active against whatever variant becomes emergent.
All right, thank you. Another question from Catherine. Right now, COVID treatments are mostly covered by insurance. Do you expect that to change in the near future? If so, what impact might that have on patients or their interest or willingness to take these treatments?
I can say for the monoclonal antibody program that this is either covered by the insurance or administered for free because these products are already bought by the federal government for distribution nationwide. And for those who are underinsured or uninsured, we have a mechanism to basically make it available to them for free.
Yeah, and the only thing I'd add to that is I don't anticipate that will change anytime soon.
Good. All right. This question from Liliana Salgado. How will Omicron impact the approval by the FDA for the antiviral at home pill? Might this delay it?
So I don't think so. And it's for the reasons that I said earlier, that the mechanism of action of these two pills, and there's another question there, so maybe I'll merge the two questions together. What is the mechanism of action? So molnupiravir induces hypermutation of the virus, meaning that when the virus replicates, it makes errors in the replication of the individual bases in about 25% of the bases, which means you have a hypermutated virus, which means it can't work. And that's its mechanism of action. The mechanism of action of Paxlovid is to block the protease, which is a necessary enzyme in the life cycle of the virus. Because these two mechanisms of action have nothing to do with the spike, I don't believe that the existence of Omicron or any other variant is likely to impact the timing of their approval. The second question was that the molnupiravir FDA advisory panel had a very close decision to its approval. And what is the reason underlying that? So there are essentially two reasons underlying that I'm aware of. That having been said, I'm not on that committee, so I was not privy to their discussions. But the two concerns that I think are most dominant in that split decision are, number one, how the drug works. The drug causes hypermutation, which means the virus is not fit. We don't yet know the safety of that drug in special populations. For example, in the context of pregnancy or in the context of women who might become pregnant. That's number one. There's also theoretical concerns that molnupiravir might drive the emergence of different virus strains. We don't know that, but that's a theoretical concern. The second reason I think for the split decision was the lower efficacy that was described in the final analysis that Merck put forward. Their analysis said that molnupiravir was effective at reducing hospitalization and or death in 30% of patients. Given that we have approved therapies or EUA approved therapies, such as the monoclonal antibodies, which are effective at reducing hospitalization and death in the 90% range or so, one could argue that if you have an existing therapy that's 90% effective, why would you move to a therapy that's 30% effective? So I think that's a lot of the questions surrounding molnupiravir. Paxlovid has not yet been reviewed by the FDA Advisory Committee. Its prior news releases suggest that it's also in the 90% range. So I think that the FDA Advisory Committee for Paxlovid is more likely to have a more unanimous opinion for its approval, given that the results are roughly the same as monoclonal antibodies, but have the advantage of being an oral therapy. And monoclonal antibodies are outstandingly efficient, but it requires a lot of work and a lot of infrastructure to administer them, given that they're IV therapies.
All right, thank you. Dr. Rosanobli, did you have anything you wanted to add on that?
Nothing else. Dr. Badley had kind of got them all.
And then question for Tina. I believe that Dr. Badley just addressed the question that you have in the chat. But if you feel like he didn't address the whole thing, can you just put that in the chat and we'll come back to that? And then in the meantime, could one or both of you answer, how long might it take to know if the antiviral pills will work against Omicron? And can we expect an oral antiviral for children?
Ray, do you want to take that?
So the for the molnupiravir, at least that the data that was reviewed by the FDA, it specifically did mention that this is only for 18 years and older, just because it hasn't been studied in children. I think that's a simple answer to it.
Okay. And what do we know about Omicron and the antivirals?
Well, since Omicron is deficient in terms of its, or mutated, I should say, in terms of its spike protein, I would anticipate that molnupiravir should work, as well as the Paxlovid should work against the Omicron variant.
Okay. But we don't have data yet because the Omicron is so new.
That is correct. Although we don't have data, and the response I mentioned was just based on theoretical assumptions.
Got it. Okay.
Mm-hmm.
All right. Let's see here. This question from Umair. Some of the early news seems to show that Omicron is more transmissible, but leads to less severe outcomes in terms of the public health burden. What are the implications of more virus spreading more readily, but less severe? Would we still expect a rise in hospitalizations because more people overall are getting infected?
Outstanding question, and it's a question everybody's asking right now. I think there are two possible scenarios, and the truth will probably lie somewhere in between. So probable scenario number one is if those two statements are true, meaning it's more transmissible, but we have less severe disease, and we don't know if that's true yet, but I agree, the initial reports seem to suggest that. Possible scenario number one is we'll have more cases of less severe severity, and that will mean that fewer people have to go to hospital. The second possible scenario is more cases, but because it will likely impact more of those who have not yet been vaccinated, the total number of cases will go up. The fraction of cases that requires hospitalization might be lower, but because of the sheer number, we see lots more hospitalizations. So really, we don't know. I'd point out, as Dr. Rosanable said earlier, and I mentioned earlier as well, that it is probable that vaccination will have some activity against the Omicron variant. It's not going to be zero. It's going to be some degree of protection. So I think it bears reminding that the best that the public can do today, and that remains true in the setting of the Omicron variant and future variants, and we will see other future variants, is the best we can do is to encourage vaccination and boosting according to current recommendations, to continue to practice masking and social distancing in congregate settings. As I go out to the grocery store and other places, I see a minority of people masking, and I think it's appropriate that we should reverse that and do more to maintain those public health measures. And then the third is when you have symptoms, to be tested early so that if you are infected, you can isolate and stop the spread. And if you need therapy, get therapy quickly so that you get better quickly. And there's emerging evidence that people who are treated might spread less. So all three are necessary: vaccination, public health interventions, and early testing and treatment.
All right, thank you. Dr. Rosanable, I'll toss this one to you. Could molnupiravir and Paxlovid be used together? Is anyone testing that cocktail?
Theoretically, since they are acting on different mechanisms of action, they could potentially be used together, but I am not aware of any study being done to test that combo. The issue that I have with that is when they come, it will come in not enough amount of products to be distributed widely. So my suggestion is one or the other. And just because there's not going to be enough products to be distributed to people that will need it the most. So distribute it widely, but likely as a single drug.
Okay, and similarly, for monoclonals and these antivirals, would they be used together? Or
Potentially, yep.
either or?
Yeah, potentially could, similar to my response earlier, but it should be either or, just because there's so much demand for treatment because the cases in the communities are so high that if at least one product is known to be efficacious, then there's no reason for combining products together.
All right, thank you. Okay, questions are slowing down in the chat. So journalists, you can continue to put your questions in the chat. If any of you would like to unmute yourselves and ask questions directly, that's fine too.
Hi, this is Tina Say with Science News Magazine. I have a question for either of you. When we're talking about monoclonal antibodies, they have to be given by infusion, and I'm just wondering, like, how widespread are like infusion centers where people can actually get this therapy, and how might the pills change that equation about who could get the therapy? How widespread, would they actually be available anytime soon?
Okay, I'll take the first crack on this one, Andrew, and then you can just supplement my answer. So there's a list of infusion facilities that could provide monoclonal antibodies throughout the country, and this is available through the HHS website as well as the National Infusion Center associations, and patients out there can just go into those websites, put their zip code number in there, and it will direct them to their closest facility that they could reach out to. It is logistically challenging just because we need the patients to come in and get their IVs started, infusion for about 30 minutes to an hour, and then another hour of observation. So as you could imagine, the capacity to infuse is outstripped by the demand for these products currently. But we do have at Mayo a well-running program that has infused anyone that have requested for it or are eligible. And we've been doing that. What I see will happen as the oral antivirals will become authorized is that it will help mitigate that demand. There will be patients that will prefer oral over the IV infusions, for example, and that will lessen the burden to the infusion facilities. I would anticipate that the eligibility criteria for the pills will be somewhat similar to what we are using for the monoclonal antibody program, that patients are supposed to be at the high risk category for progression to severe illness. So they will be capturing the same population, and patients will now have a choice on whether they go for the IV infusion or the oral pills, depending on their preference. Andrew?
I agree with everything Ray said. I think the orals, once approved and once we have more experience with them, could offer game-changing differentiators, meaning that the cold storage requirement is different. The supply chain logistics are different and easier. And last week I was at a World Antiviral Congress where we talked a lot about the prospect of these oral antivirals. And one of the goals of a number of agencies, including Gates Foundation, for example, is to create pills which can be produced at $10 or less per pill, per treatment course, for use in rural areas within developed nations and for all areas within undeveloped areas, with undeveloped nations, so that we can get these therapies to those who need it most. And it is probable that that can occur with one or either of these medications. So first off, the formulation of molnupiravir is such that it should be able to be made at less than $10 per treatment course. So that's good news. The Paxlovid, we don't know yet the cost, but there are already discussions about allowing generics in some of the most effective areas. And so I think that's very, very probable. One of the scientific issues that we need to understand more before we roll these out as very widespread use is, do any of these drugs result in treatment emergent resistance? So for example, with HIV medicines and hepatitis C medicines in the past, when people started to take them, some of the viruses became resistant to these medicines. We've not seen that so far in the SARS-CoV-2 COVID era, possibly because treatment courses are short. So that's less likely to select for treatment emergent resistance, but I think we have to monitor for that. And assuming that we don't see anything, I think there are huge opportunities for these oral antivirals, which I'd call first generation oral antivirals, as well as future generation oral antivirals, to really change the trajectory of the pandemic.
All right, thank you. I want to step back a little bit. On Friday, the FDA announced that monoclonals would be approved or are approved now for kids. And so since we don't have an antiviral pill that might be in use for kids, can you talk about monoclonals for kids, which ages, how would parents know if this is an option? Can you speak to that, either one of you? Or both?
I can take that. So last Friday, the FDA expanded the eligibility criteria for monoclonals for the bamlanivimab etesevimab product, not for all. And this is now allowed to be given to as young as a newborn who develops COVID. But they have to be considered to be at the high risk category, including those that have underlying diabetes or obesity. Our pediatric partners in Minnesota are looking into that emergency use authorization, because it's a different process. Now we have kids, now we'll have parents giving approval and for those authorizations, as well as how can we make it available in infusion centers that are used to infusing adults, for example. So all of those processes are being worked on currently, but it will be available to them for those that are eligible. High risk and the age criteria has been expanded to newborns for the bamlanivimab etesevimab compound.
All right, anything to add to that, Dr. Badley?
No, I think he covered it perfectly.
Okay, and then Dr. Rosanavli, if I'm hearing you correctly, we're not yet doing those infusions for kids here at Mayo or in the health system. We're exploring how we can make that happen.
Correct, because the dose still has to be defined, as well as the expertise of people that will be providing those infusions are still being identified.
One thing I'll add now is that the logistics and staffing and facility needs to administer these monoclonals is significant. And Dr. Rosanavli has led the team that has done, I think, a remarkable job in executing that within the Mayo system. Because of our capabilities and our staffing depth, we've been able to scale it more than many other centers have scaled. And that is the limitation with this therapy, albeit being very, very effective, it's not logistically easy to administer.
Yeah. And if I could just make a shout out to our nursing colleagues who've made this possible out there. Like for example, we have one infusion center that infuses 50 slots per day. At a time when the demand was so high, they were able to kind of flex up the staffing capacity, and they were able to infuse 100 that same day. So thanks to the work that was done.
All right, awesome. Yes, we know the nurses are working hard everywhere these days.
Mm-hmm.
All right, looks like Rich has a question, which Kelly is going to follow up with you later on that, Rich. We'll see what we can get for you.
Oh, the numbers? Yeah, we are busy.
Yeah.
We are busy.
Busy. I'll tell you that much, huh?
Yeah.
Okay, and then Paul Scott has a question here. Do we know the cost of the oral antivirals?
So not yet. Given that the process for rollout of these drugs is very likely to mirror the rollout of the monoclonals and other drugs that have been used so far in the treatment of COVID, I anticipate that the initial cost will be covered by the federal government, and so it will be free in the near term. As I mentioned, I've heard discussion, I haven't validated the discussion, but I've heard discussion that the cost of molnupiravir can be as little as $10 per course. I don't know the cost of Paxlovid so far.
All right, great. So looking ahead, what questions are the experts asking or beginning to explore now regarding COVID treatments? What's on the horizon?
So several things. So we now have an armamentarium of a number of therapies that have received EUA approval. And for most severe viral infections, it is common to have combination therapy. And so one of the things that is being discussed and studied, and I think we'll see trials very soon, is the issue of combination therapy. And the combinations can be combinations of different antivirals, as was asked earlier in the commentary. So that's going to be discussed. The second will be the use of these drugs in a post-exposure setting. So we know that for high-risk individuals who are exposed, there is a significant chance of developing infection and/or disease. We know in the HIV world predominantly that post-exposure can prevent infection. So there's discussions now about using these antivirals at first in an experimental way to determine what's the efficacy of them in a post-exposure setting. And there could be discussions about using these in a pre-exposure setting. There's been some studies of pre-exposure prophylaxis using monoclonals. For example, those patients who have chronic medical illnesses which make them less likely to respond to vaccination and therefore more likely to have high susceptibility to infection. So those studies thus far have been predominantly in nursing home residents where there have been great efficacy of prophylaxis with the monoclonals. I think we're going to start seeing those prophylactic preventative kind of studies expanding to the oral antivirals in the near term.
Anything to add to that, Dr. Razanable?
Yep. If I may add, the AstraZeneca monoclonal antibody that has done some trials is also in front of the FDA. And just like what Dr. Badley had mentioned, this is probably going to be authorized for immunocompromised populations that are not likely to have responded to the vaccines. This is anticipated to come soon, but that's going to be something that's new on the monoclonal antibody front as a pre-exposure prophylaxis in the highest risk patients who are unlikely to have responded to vaccination.
Okay. All right, just to level set, help us understand the current state of spikes and COVID numbers around the country. What is fueling these spikes? New cases in the unvaccinated, breakthrough cases, or people letting their guard down, or what do you suggest?
All of the above. Yeah, it's all. I think there's not a one response to that. It's basically all. So we know that the cases in the unvaccinated patients who are high. We also know that breakthrough COVID do happen. So all of those really contribute to the transmission in the community. And just like I think Dr. Badley had mentioned this earlier, that when he goes to the supermarket, the minority are masked. And this is in an era wherein the transmission in the community remains very high. I myself mask up whenever I go to public places, even if I've been vaccinated and boosted, just because I am also at risk of getting breakthrough infection if I get exposed to it. So all of this measures different layers of protection. I call it the wall of prevention or the circle of safety, wherein patients have to be vaccinated, their friends and family have to be vaccinated, the community should be vaccinated, but if not, there are other mitigation strategies such as masking, frequent hand washing, and socially distance or avoid public places unless you have to. And if you do, you have to wear the mask.
The only thing I'd add to that is I believe, I don't know of data to support this, but I believe that a number of these cases are due to the cold weather. So the spikes in incidence are occurring in those northern states, coincident with the onset of colder disease. And I think that means that people are spending more time indoors and putting themselves in settings of lots of people being around, and coupled with the lack of masking, I think that's contributing to some of the spread. Other states like Florida, which are pretty nice right now, I was just on a Zoom with colleagues from Florida and it's 75 and sunny today. I think that's less of an issue. So I think the colder weather is contributing as well.
Gotcha. All right, a couple more questions here. With Omicron circulating, what would you advise for holiday travel?
Right?
Get vaccinated is going to be the number one. And I know the airports and the planes, they're still mandating everyone to be masked. Bring your hand sanitizers to kind of wash your hands as much as possible, and travel only if you really have to travel.
Okay. Anything to add, Dr. Badley?
Not a thing.
Okay. All right. As variants continue to emerge, is the cocktail combination of monoclonal adapted or changed, and will the oral version evolve to maintain efficacy?
So I think the first part of the answer is that viral variants are guaranteed, and viral variants are guaranteed to evolve over time. So in some period of time, I don't know if it's 2 days, 2 weeks, 2 months, or 2 years, but we'll have another variant, and that is guaranteed. And every variant will have a unique constellation of mutations that will raise theoretical concerns about the activity of drugs and monoclonals and vaccines. And I think the answer goes back to one of the first questions we discussed today, that protection by vaccination and efficacy of therapies is not all or none. It's a linear scale. And so it is possible that some of the variants may have lower susceptibility against vaccination or monoclonals. But it's important to note that it is unlikely to be zero. Will we need novel preparations of vaccines or monoclonals? It depends how much of that efficacy is diminished. If it goes from a 90% efficacy of a monoclonal against the Delta strain to an 80% efficacy against a new novel strain or Omicron, I think it's unlikely we're going to get new preparation. If that reduces down to 20 or 30%, I think it's probable. But I think it's also important to understand that the process of creating a new vaccine or a new monoclonal is relatively simple from the scientific perspective in terms of what it takes to make that. It's not relatively simple in terms of the approval process. Clinical trials need to be done again to assess the safety, biodistribution, and efficacy of these studies, and that takes months and months. So that's a very long way of saying, I don't know.
Fair enough. Fair enough. The Omicron, so we've heard that the Omicron is, it spreads easier, but it's less severe. So is that a good sign? Does that mean that the mutation is fizzling out, or is it just random?
Right?
Yeah, that's just the preliminary observation.
Okay.
And we don't know yet if that will stand the test of time as the Omicron spreads. So I wouldn't really kind of latch into that information right now. It's a reassuring observation, but we really have to kind of see how it plays out. There's still a lot of unknowns about this Omicron variant.
Got it.
And I'd add a little bit to that. So the reason that new variants emerge is a product of evolutionary pressure, meaning that lots and lots of new variants emerge every day, but some of those variants are more effectively killed by the immune system or our antivirals or our monoclonals. Those ones don't grow. Those ones don't become dominant in the community. The ones that are not effectively covered or not as effectively covered or spread better are the ones that emerge in the community. So the fact that this Omicron variant is becoming dominant in at least South Africa means that it spreads better. But the evolutionary pressure that selects for its emergence has nothing to do with how sick it makes people. So it is possible, we don't know yet, as Dr. Rosnable said, it is possible that this could spread better but cause less severe disease. And if that's true, that can help to increase the net state of immunity in our society, which would be a good thing. But I think it is very, very premature to say that disease severity is less. Part of the reason is that the cases that we've seen thus far have been predominantly in South Africa. It was a very heavily vaccinated population. In other countries, it's been young, healthy people who have presented as outpatients. So it's a very biased population. We don't yet know the incidence of Omicron in the hospital setting. And that's a critical piece of information.
Okay. All right, a question here from Paul Scott. Can you elaborate on how the Merck pill can cause viral mutation and that is not a concern?
Yeah, so it's a great question. The way that many antivirals work is that they create what's called a nucleoside, which gets incorporated into the DNA or RNA chain. In the case of molnupiravir, that nucleoside does not stop replication, but it causes the virus to incorporate a wrong nucleoside as its partner, as its binding partner. And so it creates what's called hypermutation and DNA catastrophe, or RNA catastrophe in this case, which means that the virus just can't replicate. So that's how it works. How is it not a concern? I think it is a concern. And we just don't yet know what the effect will be in our population, which is why there was a split decision at the FDA advisory panel. It was a concern which led to that split decision. And so really we need more information before we can say what the role of molnupiravir will be in our therapeutic armamentarium.
Okay. All right, we have just a little over 10 minutes left. Questions are kind of slowing down. Journalists, you're welcome to continue putting questions in the chat or unmute yourselves and ask directly. Is there anything else that you guys, Dr. Badley and Dr. Rosanabli, that you would like to add or emphasize?
No, just basically to kind of state that, it's been, yes, almost 2 years now since this virus was first suspected in China in 2019. And what we've learned is, things change, things evolve. Information that we know now will likely evolve and be adapted, and the different information comes up in the future. So basically, to kind of emphasize that it is still rapidly evolving, and that new information comes up each time. Andrew?
I agree. And I'd emphasize that we as a society have in our power the ability to slow transmission and spread through all of the things that Ray and I have both said, which is vaccination. These vaccines have been tested in more people than any other vaccine in history. They're safe, they're well tolerated. The early concerns about blood clots, et cetera, they have been largely dispelled and put in context that they are very, very, very rare events. And any medical intervention is a balance of perceived risks versus perceived benefits. And to the way I put things together, the perceived benefits of vaccination greatly, greatly outweigh the perceived risks. We know that if you are infected and you've been vaccinated, your disease is less and you're less likely to die. We know that our hospitals are filled today with people who have been unvaccinated or cannot respond to the vaccine, by and large, for medical conditions or medical treatments that we as physicians prescribe. And so I think it is incumbent upon us to encourage all of our friends and loved ones to be vaccinated, to be tested at the first signs of symptoms, to quarantine, to get tested and treated, and to wear masks and social distance and maintain a safety net, as Dr. Rosanabli described, for the foreseeable future.
Gotcha. So Dr. Badley, my colleague Jim is just asking me for clarification or maybe additional color commentary from you. You mentioned that warmer weather climates maybe aren't seeing as much of a problem. Colder weather seem to be seeing more of a spike. But, in Arizona, there are spikes right now. Can you give any insights or perspective on what's happening in Arizona?
Yeah, so cold weather is not everything, right? So all of the other risks that we've discussed throughout this remain in effect. And so I think cold weather is, excuse me, cold weather is associated with the current spikes in Michigan and Minnesota, but that's not the sole cause.
Okay, fair enough. All right, I'm going to put a last call for questions. And journalists, we will have a recording of this session available on newsnetwork.mayoclinic.org. So if your recording doesn't work, you can check that later today, and a recording will be available, the full session. Just email us if you need the link or can't find it. And with that, I don't see any other questions. So I just want to thank you again for your time and expertise. And thank you, journalists, for attending. And have a great week.
Thanks, everyone.
Thanks, everybody.
Thank you.
Recording stopped.